This talk is about ultrasound imaging for endometriosis. My name is Suzanne Johnson and I'm a gynecologist from Southampton. In this talk we're going to discuss the myth that's at least partly responsible for the 8-year diagnostic delay, and the idea group who wrote Language and a System for Endometriosis Ultrasound. It consists of 4 steps where you do a systematic pelvic scan, look for the sliding sign, nodules of deep endometriosis and soft markers for endometriosis, and at the end I'll show you some resources. The myth is that you cannot see endometriosis on ultrasound. This is just not true, and I'll show you why. This paper came out last year, and it shows that ultrasound has a very high specificity and sensitivity for ovarian endometriosis, deep endometriosis and pouch of Douglas obliteration. It does require a high level of training, but with that you get very high sensitivity and specificity. This beautiful image from this paper shows what endometriosis looks like on speculum examination, deep endometriosis, what it can look like at laparoscopy, and what it looks like on ultrasound. And for me, certainly ultrasound would be the easiest way. So normally when we scan the pelvis, we do a routine pelvic ultrasound. Now the problem is this looks mainly just at the uterus and at the ovaries. To look for endometriosis, you also need to look for deep endometriosis, mobility, looking for a frozen pelvis, and site-specific tenderness. So the idea group wrote a language and a system consisting of 4 steps, and I'll show you in a minute how I do these 4 steps. They can be done in any order. First, the language. Language really matters. And using the idea group's terminology, if you draw a line through the internal os, then behind that is the torus. If you draw a line below the level of the cervix, then the tissue between vagina and bowel is the rectovaginal septum. The area above that line is the posterior vaginal fornix. You've got the pouch of Douglas between the cervix and the rectum. The bowel below the level of the torus is the lower rectum. The bowel above the level of the torus is the upper rectum. The bowel above the level of the uterine fundus is the sigmoid colon. So you have a posterior compartment, and common locations for deep endometriosis are the posterior vaginal fornix, the torus, the lower rectum, the upper rectum, or sometimes it all becomes adherent together and you have a frozen pelvis. So how do I do the idea system? I start with a systematic routine pelvic ultrasound, but I'll be looking out for features of endometriosis such as adenomyosis, ovarian endometrioma and ovarian adhesions. So for my standard systematic TV scan, I ask the patient to have an empty bladder, but I don't use routine bowel prep. The main thing is to be gentle. Have the patient's bottom overhanging the edge of the couch, don't use a wedge. Use knee supports or have her feet on the chair. And encourage her to let your knees go floppy, as this makes all the difference. And then slowly insert the probe with plenty of lubricant on the outside of the probe cover and perform a systematic pelvic scan. Just the orientation, how I orientate my images is a very common way. Where the uterus points toward the bladder, it's anteverted. Remember that on ultrasound and laparoscopy, everything is the other way around. So uterine position, just very quickly, this is an anteverted uterus, a retroverted uterus. This uterus is anteverted but retroflexed, and that's incredibly important in endometriosis ultrasound. And this uterus is axial. So features of endometriosis, I'm going to look for a uterus that's anteverted but retroflexed. And the reason why this is common in endometriosis is you get adhesions behind the uterus which pull the uterus back into retroflexion. This causes the question mark sign as described by Nadine Di Donato. I'm also going to look for adenomyosis, and this is beautifully described in this paper from 2019, looking for a lot of different features of adenomyosis, such as a globular uterus, asymmetrical thickening, cysts, hyperechoic islands and fan-shaped shadowing, but also some more subtle signs as described on the right. So here's an example. This uterus is anteverted. You can see that it's bulky, it's globular. The endomyometrial junction is very hard to see. There's small myometrial cysts. There's that junction just there. Small myometrial cysts and fan-shaped shadowing. This is adenomyosis. This is another example of adenomyosis. This is worse in many ways. There are islands of endometrium in the myometrium causing hemorrhagic cysts. Islands of endometrium in the myometrium, just there. And if you do a 3D scan, you can see this very irregular endomyometrial junction. A low ovary you should suspect adhesions. A lot of people will comment on a low ovary and not realize why it's low. So if you see an ovary here, which is low in the pelvis, this is where the bladder attaches to the uterus. This is the internal os. This is the torus. So this ovary is adherent to the torus. If you go to the transverse plane, patient's right, patient's left, you can see that this ovary is at least sitting on the left uterosacral ligament, if not adherent to it. You'd need to see a video clip. The ovary, we're going to look for ovarian endometriomas, and this is an example of one such. Describe this using iota terminology. This one is a unilocular cyst with ground glass echogenicity contents. You can also see a little bit of shadowing from a hyperechoic calcified focus on the cyst wall. Again, in the transverse plane, you can see this ovary is low and it's very close to the uterosacral ligament and it's adherent to the uterus. And if you compare that to the other ovary, the right ovary, which cantilevers when you press very gently on it, you can see that the left ovary is stuck and the right ovary is freely mobile. If you stay in the transverse plane, this is the right ovary, this is the left ovary, and you can see that they are stuck to each other, they're kissing ovaries, and also adherent to the back of the uterus. The important thing is that if you found an ovarian endometrioma, there will be deep endometriosis somewhere. You have to look for it. Next, we're going to do the sliding sign in the pouch of Douglas, and these papers about the sliding sign were published in 2013. It's important to think about where to put the TV probe. It's different in an anteverted as opposed to a retroverted uterus. In the anteverted uterus, where the bladder is pointing, the uterus is pointing toward the bladder, this is the anterior fornix. If you put the probe in the anterior fornix, you can see the cervix clearly, and in an anteverted uterus, we can see the sliding sign of cervix against bowel. If you put the probe in the posterior fornix, you won't see the cervix. You can't do the sliding sign, but you will be able to see bowel nodules and adhesions, as we'll do later. So anterior fornix in an anteverted uterus. So this is a normal sliding sign. Anteverted uterus, I've got the probe in the anterior fornix, and you can see with very gentle pressure, just with the probe hand, the uterus is moving one way, and the bowel and all the tissues behind the uterus is moving the other way. You can see that things are moving in different directions. This is an abnormal sliding sign. Again, anteverted uterus, where we've got the probe in the anterior fornix, and you can see that all the tissues behind the uterus, they move, but it all moves together. There's no sliding here. This is a frozen pelvis. In a retroverted uterus, here, the bladder would be here, so the uterus is pointing toward the patient's feet, away from the bladder. If you put your probe in the anterior fornix, as here, you can see the cervix, and you'll be able to see sliding here, but we need to know what the sliding at the torus is like, so that's the wrong fornix. If we go into the posterior fornix, we'll now be able to see the torus, which is at the back of the cervix, and look for the sliding sign of uterus against bowel, and also find bowel nodules and adhesions. So we're going to look at the normal sliding sign in a retroverted uterus, probe in the posterior fornix, so the cervix is up here. And you can see I'm very gently pushing that probe in and out a little bit. And I can see pouch of Douglas with a nice bit of fluid, bowel behind, everything moves in different directions. This is an abnormal sliding sign. Again, probe in the posterior fornix. You can see that there's movement, but the bowel and all the tissues behind are adherent to the uterus. This is a frozen pelvis. So what's the problem with diagnosing endometriosis on ultrasound? I think the problem is the way that we've been trained to scan. We look at the uterus and the ovaries and not a lot else. It's a bit like walking into a room only looking at the ceiling. If you only look at the ceiling, you're never going to see the rock that's on the floor. It's the same with ultrasound. If you only look at the uterus and the bladder, you're not going to see the rocks of deep endometriosis in the posterior compartment. So what do these nodules of deep endometriosis look like? We need to look for them in the posterior compartment, vagina, ligaments and bowel, that's all behind the uterus, and the anterior compartment, bladder and ureter. So starting at the vagina and the posterior compartment. This is what a normal posterior vaginal fornix looks like. We've got the cervix there. This is the external os. This is the cervical canal, the internal os, and the rest of the uterus is up there. So we're just going to be looking here, which is the posterior vaginal fornix. If you draw a line through the internal os, you've got the torus behind. And here I'm just going from side to side, and you can clearly see the cervix, you can see the cervical canal, and then that little pouch behind the cervix, which is the vaginal fornix. So what would that look like affected by endometriosis? There it is. There's a lump of deep endometriosis. You can see normal thin vagina, thin, 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 and here is a nodule of deep endometriosis in the posterior vaginal fornix. And it looks just like that, and on speculum examination, if you look behind the cervix, you can see that nodule of deep endometriosis on speculum, but this is relatively easy to miss. It's easier seen on ultrasound. Then we need to look at the ligaments and at the torus and the uterosacral ligaments. So looking toward the patient's feet, the posterior uterus, the torus, uterosacral ligaments, and the pouch of Douglas. What would that look like on ultrasound? So we need to visualize the torus. So this is a longitudinal view of the torus, just at the back there. And I'm going to go side to side a little bit in the longitudinal plane and then rotate to transverse to look for the torus and the uterosacral ligaments. So side to side, just to orientate myself, rotating through 90 degrees. This is the torus behind the cervix, and this white line is a normal uterosacral ligament and one on the other side. So you can see they're incredibly difficult to see, these very fine white lines, and that's fine. You can see nice normal mobility, a thin white line. That means the uterosacral ligaments look normal at that particular location. So that's a transverse view of the torus and the uterosacral ligaments. So normal looks like that in both views. Deep endometriosis causes retrocervical fibrosis and these thick white uterosacral ligaments. And if you look close in the retrocervical fibrosis, you can see here a nodule of deep endometriosis. If you put your probe in the vagina and you're thinking about where you are now, you can see that if you very gently insert it through the vagina, you'll be pushing gently against the uterosacral ligament. So what does that look like on ultrasound? The uterosacral ligaments blend into the peritoneum, overlying the posterior vaginal fornix when you very gently press. This is all done very, very gently. So I'll show you, this is a retroverted uterus. This is a bit of fluid in the pouch of Douglas, and in a minute you'll see a uterosacral ligament appear, and as I press my probe in, that will become blended onto the peritoneum here. So the first layer is vagina, then we've got peritoneum, and then we will see a uterosacral ligament. So if I play the video, there is the uterosacral ligament, and with me gently pressing, it becomes applied to the probe. So the tissues overlying the probe are also the uterosacral ligaments. vagina, peritoneum and the uterosacral ligament. And so when I'm pressing slightly, that is another place where you can see the uterosacral ligaments. So what would a nodule of deep endometriosis look like in this thick uterosacral ligaments or retrocervical fibrosis? It looks like a dark, irregular, hypoechoic nodule outlined by this white fibrosis. The way to see that is with your probe in the vagina there. You need to use high frequency, including the highest frequency of harmonics, and then also use your focus up. Move your focus up so that all your focus is here, just at the tip of the probe. If your focus is down there somewhere, you will never see this nodule. So high frequency with harmonics and a high level of focus, and those nodules will just pop out at you. You can also see bowel nodules. And again, you need to just think about where you want your probe to be. In the anterior fornix, you can see the sliding sign nicely, but it's harder to see the bowel. If you put your probe in the posterior fornix, it's harder to see the sliding sign, but you get to be right up close to the bowel. So you can look for bowel nodules and adhesions. So moving the probe from the anterior to the posterior fornix is what we do this way. So here I've got a little video clip of the cervix, the little bit of mucus in the cervical canal. I'm angling the probe backward toward the sacrum and just gently putting that probe in the vagina. I'm now on the posterior fornix, that's the pouch of Douglas, a little bit of free fluid. I can go side to side looking at the ligaments, and then this is the normal reflection of the pouch of Douglas, and now I'm back in the anterior fornix. So when you are in the posterior fornix, you can see the bowel very nicely, and people worry that they don't know where they are, but you do know where you are. You're just in the posterior fornix, so the uterus has been pushed out of the way. So when you're in the posterior fornix, you can see the bowel, and these are the different bowel layers. This is the serosa. This triple layer is the muscularis. Then there's submucosa and mucosa on both sides, muscularis on the other side, and serosa on the other side. So you've got the anterior bowel wall and the posterior bowel wall, and the lumen is just there. And this is nicely outlined because there happens to be some fluid in the pouch of Douglas with this normal peritoneal reflection. A bowel nodule of deep endometriosis looks like this. You can see this thick muscularis layer. It should be like this, a nice thin layer, and when it becomes thickened like that, that's a bowel nodule. So when you first insert your probe, and you can practice this on every normal scan if you like, you can pick up the white is serosa, the dark white, dark is the muscularis layer, and you can track that as you insert your probe. And you can track it, track it, track it. And you can see how I'm able to track that bowel layer all the way through. You can often track it all the way up to the uterine fundus. So there it is again, tracking that muscularis layer as you insert the probe, and you might lose it a little bit now and again, but you soon pick it up again, and you can track that layer all the way through to the uterine fundus, looking for bowel nodules of deep endometriosis. And this is one such bowel nodule, and you can see muscularis going into it and coming out of it again. There's a thick muscularis layer with a bright white overlying submucosa, normal muscularis on the other side, and then serosa covering that. So you can see that the posterior bowel wall and the anterior bowel wall are very discordant. If you put colour on, you can see that it's not very vascular, this bowel nodule. If this was vascular, you would have to think of alternative diagnosis. And in this case, you can see a bowel nodule again. I'm going from side to side, having found it. I'm looking for muscularis going into it and going out of it. There's the normal muscularis going into it. This is then the bowel nodule, the thickened muscularis. This is normal going out of it. And you can see this retrocervical fibrosis, which makes it stand out, and these nodules of deep endometriosis. And sometimes you get all three layers involved with endometriosis, as in this case. So you can see here a very thick posterior vaginal fornix. It should be a thin dark line, but it isn't. It's a thick line. She's got retrocervical fibrosis, deep endometriosis within, and a bowel nodule. And I'll just play that again and show that you've got affected fornix, ligaments, and bowel. And this would be palpable through the posterior vaginal fornix and is still described as a rectovaginal nodule. You can also say what level the deep endometriosis is present at. If it's below the torus, it's the lower rectum, as in this case. You can see that bowel nodule appearing. We haven't got to the cervix yet. The cervix is up here. So this is lower rectum. And again, it's outlined by this very bright white submucosa, and it's that often makes it stand out. You can have lower and upper rectum involved by endometriosis. So again, lower rectum below the torus, upper rectum above, and this is shown in this video clip. That normal, and then it becomes thickened, and it's thickened all the way nearly up to the uterine fundus. That's a very large bowel nodule affecting the lower rectum and the upper rectum, spanning the torus. And this is really bad endometriosis. It's in the bowel. It's a very large upper rectum and sigmoid plaque. It becomes sigmoid at the level above the uterine fundus. You can see all sorts of other things there of endometriosis, but a very, very large bowel nodule spanning upper rectum and sigmoid. Sometimes you see more than one nodule, as in this case. We've got one in the lower rectum, and then we've got a couple by the left ovary. And I'm going from side to side here, and this is a sigmoid colon. You can see a thickening there and there. Again, look for normal muscularis going in and coming out, 2 more separate bowel nodules. You can look at the angle of the bowel nodule, which is an extremely important thing to do. Sorry, it's all skipped over a little bit. You can see that the angle of this nodule here is flat. If this is it in, I've made it a bit bigger, so this is a flat nodule. And in the transverse view, this is the width of the bowel, and that's the width of the nodule. These are things that we can measure. Width of the bowel nodule. But a curved bowel nodule, you need to start thinking about stenosis. If the bowel nodule is curved like that, we look at the angle of the curvature. We look at the thickness of the plaque. Only include bowel endometriosis here. Don't be tempted to include the DE in the ligaments. And then we also measure the width of the bowel and the width of the deep endometriosis on top of the bowel, in the bowel wall. So if you get a retracted mushroom nodule, if the angle is less than 90 degrees, or if more than half the circumference is affected, or if that AP diameter is more than 1 centimetre, you've got to think these are surrogate markers for bowel stenosis, and this is a very important thing to know preoperatively. Distance to the anal verge is very important, described beautifully in this chapter. The first rectal curve is at 3 centimetres from the anal border. The second curve is at 8 centimetres. The peritoneal reflection and the lower edge of the cervix are at 7 centimetres, and the torus about 8 to 10 centimetres. And knowing those landmarks will help you to work out where your bowel nodule is. Again, very important to know in advance. And this is how I do it on my machine. I can see the bowel nodule. I can measure the distance from the nodule to the first anal curve, then add 2 or 3 centimetres, and that gives me a distance to the anal verge. You can also do 3D and 4D bowel pictures. It can really help with measuring the size of the nodule. So, but that's its main point, really. Anterior compartment, we can look at the bladder and at the ureter. The bladder is divided into the trigone, the base, the dome, and extraperitoneal bladder. And common sites for bladder endometriosis are the base and the dome. You need to work out where the ureters are, and you know it's a ureter, not a blood vessel, because there's vermiculation. This is the urine being squeezed into the bladder. And in the transverse view, when you're learning where the trigone is, this can make it very clear that these are the transverse views of the uretrovesical junction. So a nodule of deep endometriosis, again, is in the muscularis layer of the bladder wall. And here you can see a very, very large nodule. and that's very big. More normally, a bladder nodule would be like this, and then you can measure the distance between that nodule and the ureteric junction above it. Again, important things to be able to tell the surgeon. Ureteric endometriosis tends to be fibrosis around the ureter. You can often see this where they enter the bladder or at the torus. And this is one by the ovary. Here you can see a small hemorrhagic cyst. You can see some deep endometriosis between the ovary and the vaginal vault. And then you can see this is the ureter, and it is distended above the level of the ovary, and it is narrowed here on its way to the bladder. But this is fibrosis rather than intrinsic endometriosis. To be able to see that, it's important that you look well above the level of the ovary and increase your depth of field. And look at the kidneys. This is a different case, but it shows gross hydronephrosis. So we always check the kidneys in women with endometriosis. Lastly, we look at soft markers for endometriosis. These are site-specific tenderness and pelvic mobility. So at the end of the scan, I go around the whole pelvis again and saying at this time we're going to just see very gently if you're tender anywhere. And I, of course, can see where I'm scanning. So is the uterus tender? Is it the ovaries? Is it a different area? And then if you find a spot that you hadn't noticed before being particularly tender, look again, because there may well be some deep endometriosis there. And of course, to do a final check for pelvic mobility. How do all of the organs in the pelvis move? So I promised you some resources. This is a fantastic book. I just get it and read it several times. It takes a little while for it all to sink in. And then this wonderful website by Sophie Peason's endosonography101.com. Lots of practical examples for how to diagnose endometriosis. And of course, on my website and YouTube channel, I've got a lot of step-by-step videos for how to do this. So in conclusion, you can see endometriosis on ultrasound, but much more training is required. Transvaginal ultrasound is great for planning surgery, and it's very good for understanding the patient's pain, because in this sense, I suppose, seeing is believing. Thank you.